So hello everyone, my name is Stephanie and I'm working at the central office of ERKNet. I would like to welcome you to today's webinar, and just as a quick reminder, you all are muted, and if you have questions during the webinar, you are welcome to raise them in the question box.
Good afternoon, everybody. I'm really pleased to co-moderate this webinar with Roman on a topic that we are both very interested in, tuberous sclerosis complex, which is an autosomal dominant rare disorder characterized by the presence of proliferative lesions that can affect really any organ system. Updated general recommendations for the diagnosis and care of TSC have been published, including each disease area of TSC. However, in these clinical practice recommendations, we really focused on the kidney manifestation, as it is first the most common cause of death in adults with TSC, but also where there is a lack of guidance leading to inappropriate health care of this population with a delayed use of targeted therapeutic approaches such as mTOR inhibitors and unnecessary surgical procedures or nephrectomies, which worsen the risk of chronic kidney disease. The working group of autosomal dominant diseases of ERKNet have prioritized this initiative during the annual meeting of ERKNet already in 2021 with the amazing support of Franz, Tanya and Stephanie. We were able to integrate the input of all physicians involved in the kidney management of patients with TSC, even patient representative. But we mostly enjoyed the mentorship of John Bissler. We had also the methodological contribution of Osteba from the Iran guidelines and the collaboration of the working group Gene and Kidney from the ERA led by Roman. I am very proud to announce that our paper is accepted in Nature Review Nephrology, and we just received today that it is available online. And I give the word to Roman, who will introduce John. Roman is the speaker of the Center of Rare and Genetic Kidney Diseases at the University of Cologne, where he treats a large number of patients with genetic kidney disease, including TSC. He is also the board member and the speaker of the working group Gene and Kidney at the ERA, and I would like to thank him specifically because he did really an incredible work in this initiative. Roman, it's yours.
Thank you very much, Jalila, for these kind words. It's actually really been a pleasure to do this, and for ERA on the working group Genes and Kidney, this was really a topic that was at our hearts for the reasons you've already pointed out, because there's a major impact on clinical care in our view to provide guidance here. It's my pleasure now, John, to introduce you, and I think for people who have been in the field a little bit longer, not much of an introduction is needed. I'll still say a couple of words. It's been a huge pleasure for me, and I think the whole group, to work on this project together with you and having your guidance on this. And it'll be great to have your presentation here today. Dr. Bissler saw his first patient with TSC actually when he was a medical student in 1984. And as I learned, was intrigued by the tumors, the cysts, and also the vast differences between this specific patient and what was described in the textbooks. And still a lot of this is true, that we see a disparity between what we see in clinical care and what might be the actual things to be done. So he then became interested in this and looked into both the mechanisms and the clinical care behind TSC and tumor formation much more closely, and importantly was also the principal investigator for studies on mTOR1 inhibitors in TSC patients. And I'll have to say, for the field and for me personally, this work that was published in the New England Journal of Medicine and the Lancet has greatly changed what we can do and is the key thing we can do for these patients nowadays. Based on this work, he's listed as the leading world expert for angiomyolipoma, the website Expertscape, and is the, well, I would say, optimal person to give us an insight into the new clinical practice recommendations. He's now the director of one of the largest TC centers of excellence and director of nephrology at St. Jude Children's Research Hospital, as well as the Bonheur Children's Hospital. And John, it's been great going through this journey together with you over the last years, coordinated by Jalila, who made a major effort there, and I'm looking forward to your presentation.
Thank you so very much for that very kind introduction. It's been just a pleasure to work with all of you, and from patients, physicians, and everyone. Thank you. The objectives for my talk today are to give you a little bit about tuberous sclerosis, talk about the renal manifestations briefly, and then to go through the clinical practice recommendations. There's lots of ways to describe tuberous sclerosis. I'm going to take a little bit of a different tack. Because the TSC complex associated proteins gate or control growth, tuberous sclerosis affects fetal development and postnatal growth. So it affects growing cells while development's occurring, as well as after birth. It's considered an autosomal dominant disease, but there's a very high number of new mutations, and so that's really important to keep in mind. The major neurologic and developmental effects occur and impact most patients, and there's tumor development in many different organ systems. We're going to focus on the kidney. It's actually not that rare. Tuberous sclerosis is not that rare. It's 1 out of roughly 6,000 as far as an incidence, and it's missed. It's not often recognized by clinicians who are less informed or don't have much exposure. For example, less than 40% of patients have the classic triad, used to be called Volk's triad, of the facial angiofibromata, the developmental delay, and intractable epilepsy. So if that's your definition, you'll miss 60% of the patients. And as Jalala said, recent systematic review identifies the leading cause of mortality in TS patients as 3 major things in all ages. Epilepsy, this is associated with status epilepticus and sudden unexpected death in epilepsy. Kidney complications, and then complications from infection, for example, aspiration, pneumonia. But to highlight the importance of the kidney in tuberous sclerosis, about 40% of adult patients with TS have significantly decreased kidney function. By that, I mean CKD stage 3 or greater, and it occurs much earlier. For example, about 30 years earlier, 40 years earlier than the general population. And TSC-associated kidney disease is the leading cause of death in adults, and there are now multiple papers describing this. There are major renal phenotypes. I'm not going to talk a lot about cancer, though it does occur, it's rare. There are angiomyolipomas, as shown here in the center picture. The angiomyolipoma is the vast majority, and the kidney is down below. About half of the patients will exhibit this, and the other half will exhibit renal cystic disease, as you see over here. This is an example of a kidney that is the polycystic variety of tuberous sclerosis complex. Now, there's actually multiple different recognizable patterns of TS cystic disease. So if we take a kidney, cut it in half, remove the vasculature, we can describe these recognizable patterns of cystic disease based on where the cysts are, the location, their distribution, the size of the cyst, and the number of the cysts. In the cortex, including the columns of Burton, You can have cortical cystic disease, where you can see the cysts in the columns or in the cortex, but they're restricted to this location. They're not in the medullary rays. You can also have something that's described as microcystic disease, because the cysts are in the cortex, but they're microscopic. Now, you can actually see this on MRI imaging, specifically T2 weighted images. Well, it's easier for me to see it on the T2 because the cortex and the columns, for me in my eye, mostly the cortex, is more white than it should be. In a good T2 series, the columns, the renal pyramids should be lighter than the columns and the cortex. But in microcystic disease, you will see this. It's sometimes missed because very few things do this. It's not taught. And so your eye sometimes blows past it because you're not expecting to see it. There's also a description of cystic disease called focal cystic disease. And these are actually clusters of cysts. This is really a fascinating phenomenon. Cyst, like you saw in the large contiguous gene syndrome, the polycystic variety. These can be the same size, but they're made up of multiple small cysts. Like think of a grapefruit versus a bunch of grapes. They can be large and problematic, but they're in bunches. And then there's another term, multicystic, where they're actually cysts are everywhere. They're in the pyramids, they're in the cortex, and there's a significant loss of corticomedullary differentiation. You can't really tell where in the kidney they are. And then I showed you an anatomical specimen of the polycystic variety where you have large cysts, and this is associated with the contiguous deletion of TSC2 and PKD1 on chromosome 16. Well, I could drone on and on because this is a subject near to my heart, but let's look at a case. This is a 23-year-old male with significant autism. He has significant hypertension, and he has some real behavioral issues. And he's been followed by ultrasound. So here's a picture of the ultrasound. I want you to take a good look at this. The report was rather boring, really not much to report in the report. But if you look at the ultrasound, here's the capsule and the kidney. This is obviously the right kidney. Here's the liver. But take a good look at that ultrasound, and we'll have some questions just to see what people have to say. Now, to frame the question, he's an adult strength young man who's very wary of doctors, any healthcare personnel, or in fact, any change, including in his environment. And he has very challenging behaviors, making it very difficult to manage his care. So for my first question, is renal ultrasound adequate for this specific patient? Yes or no? And I'll give you about 30 seconds. Okay, so almost split. 40% of people roughly said, yeah, that's in this particular patient, this is fine. And about 60% of the people said, no, that's not good enough. Another question, is once every 3 to 5 years an adequate frequency for imaging? So a quarter of the people said, yeah, that's good enough, and 75% of folks said, nope, that's not going to cut it. Let's go to the next question. Would you opt for an MRI sometime after looking at this ultrasound, or was the ultrasound so reassuring you don't feel you need it? So most folks would go for an MRI. 94% and 6% said no, they just use the ultrasound. So that's really useful. Well, an MRI was obtained, and it showed significant corticocystic disease, maybe even, I'm going to get my pointer here and I'll show you what I'm talking about. It has a lot of cysts along the outside, specifically, and in the areas you can see the rays, and they're not as involved, but there are some cysts everywhere, and there are some significant fat poor angiomyolipoma. I'm going to direct your attention to the body wall fat. This is a fast spin echo T2, and here is a large, about 3.7 centimeter right upper pole lesion in the kidney, and here's a lower pole left kidney lesion. So this patient on ultrasound, the tumors were not seen because the fat poor lesions have similar echo texture, so they were missed. Let's do some questions on this then. These will again be yes or no questions. The spacing, timing-wise, was 3 years from ultrasound to the MRI. Do you think that all the cysts are all brand new since that ultrasound was done? It was 3 years ago. I put last year. It's 3 years ago. Are the cysts new? You guys are very sharp. That's right. 94% said no, they're not new. That's right. They're too small to be seen by ultrasound. How about another question? Can the cysts that this patient have, they're all small, can this lead to any significant issue, or is it just a passing finding? Can these lead to significant issues? You guys are very good. 91% said, yeah, these can lead to some significant problems. That's absolutely correct. Let's look at the tumors. Now, do these fat poor lesions need to be biopsied? Bit of a spread. About a quarter said, yeah, how about a biopsy those? And 3/4 said, no, we don't need to do that. Do these fat poor lesions need to be resected because of the risk of renal cell? It's the same sort of split. About a quarter said yes, and 3/4 said no. Now, a bit of a head spinner considering the last question. Would you treat this disease with an mTOR inhibitor? %80 said they would, about 20% said they would not. This has been really excellent because you see there's lots of different opinions. They sort of cluster, but it's difficult to know exactly what to do. This is to point out that patients with TSC kidney involvement are actually at significant risk for delayed or actually, as Jalila said, inappropriate health care. Now, to try and help improve that, patient groups have been active to support patients and family and improve knowledge, both for the families as well as for the physician community. And there are updated recommendations for the diagnosis of TSC. They're published in places that are not routinely looked at by nephrologists, urologists, and that sort of thing. And few explicitly provide information on the kidney manifestations and management. Worse than that, if you go to the literature, there's many anecdotal reports of unnecessary surgeries or nephrectomies. If you read the report, you think, well, that's what you should do, but that's not exactly right. And as Jalila said earlier, if you do unnecessary surgeries, you increase or worsen the advanced CKD. And there are targeted therapies for angiomyolipomas that are approved, and they do work for some forms of cystic disease, mTOR inhibitors. So there's ways to get at the disease that are not as invasive or destroy kidney tissue. That gave birth to the clinical practice recommendations. So all stakeholders who care for TS patients with kidney involvement, nephrologists, urologists, geneticists, radiologists, interventional radiologists, pathologists, and patient representatives were involved in gathering and working through this data and scoring the data and scoring the recommendations, and developed this systematic review to have the most current and accurate information as a single source document to be referred to. It's also open source. The paper is open source, so it's easy to get. And as you've heard already, the European Rare Kidney Disease Network, the autosomal dominant structural kidney disorders group is fabulous, and greatly appreciate the ERA working group in genes and kidney. Lots of people involved in this effort. It took many years, and they're scattered, mostly in Europe, but scattered really across the world. And I'm very grateful to have been able to work with all of them. The work, finished work, was also endorsed by the family organizations, the Tuberous Sclerosis International, the European Tuberous Sclerosis Association, and the TS Alliance in America, and the global aspect of that, have endorsed this document. Nephrology support for this is also there. Pediatric Nephrology Associations, both the European Society and the American Society of Pediatric Nephrology, endorse this clinical practice recommendation. And so does the European Society of Urogenital Radiology. So we have major stakeholder groups endorsing this document. So we'll start with genetic testing. What are the recommendations for genetic testing? And really, the cost and so forth have come down greatly. So genetic diagnosis is recommended for all patients. And if the patient has definite TS, but you can't find a disease-causing variant, then a high sensitivity genetic analysis is recommended. How to do all this and so forth is in the paper. This is a high level, just to make the slides easier. And again, if in a patient with the polycystic variety and you can't see a TSC2 PKD1 deletion, then a high sensitivity genetic analysis can help you pick up the mosaicism that is not infrequently there in new diagnosis of polycystic variety. Now, in patients with just isolated angiomyolipomas, we don't recommend routine TSC gene testing. Just an angiomyolipoma likely does have a mutation in TSC2, but if it's a small isolated angiomyolipoma, the rest of the patient probably does not. So there's no need to do the genetic testing or have that cost. And when a pathologic variant is identified in the patient, and somebody who's really familiar with TS should evaluate the first-degree family members to see who else might have it. If they have it, then if you're on the long question, you're not sure, then genetic testing could be done. But if they don't have any clinical findings, then first-degree family members really don't need genetic testing. Genetic counseling is recommended for all patients with TSC if they're thinking about having children. And this is especially important because there's such a high degree of intra-family variability of the severity. So you might have a patient thinking, well, it's not bad in my family, so it won't be bad for my children. That's definitely not how it works. And then we have statements to patients with TSC2 pathogenic variants overall have a greater severity than with patients with TSC1 pathogenic changes. And the second statement is patients with combined deletion of part or all of the TSC2 and PKD1 gene really are at a significant risk for accelerated cystic disease. So it's very important to look for that very early on. What about the diagnosis and monitoring and treatment of hypertension? This is really important in the patient population and is now getting some traction with clinicians. An annual standardized blood pressure assessment is really important. And it can be followed up with 24-hour blood pressure monitoring in children who have blood pressures above the 95th percentile for age, sex, and height, or above 120/70 for adolescents and adults. Now you can trust and use home blood pressure monitoring as an alternative to standard in-office assessment if you need to. For treatment, we recommend ACE inhibitors or angiotensin converting enzyme, angiotensin converting enzyme inhibitors or receptor blockers as the first line of therapy. And patients who are at higher risk for hypertension obviously can have their blood pressure checked more frequently. For example, patients with advanced CKD, significant angiomyolipoma tumor burden, patients on ACTH or steroids for spasms. There's really no data available that would suggest that the clinical practice for the management of TSC patients should be any different as far as blood pressure is concerned than it is for the current published guidelines for the general population, with one caveat. Trier demonstrated, I think 2014, that lower blood pressure seemed to slow progression of cystic disease in ADPKD. So for patients with the contiguous gene syndrome, I would use a lower blood pressure progression. What about when to initiate an mTOR inhibitor in patients with TSC? Well, first off, mTOR inhibition is really the first line of treatment for angiomyolipomas requiring non-urgent treatment. And mTOR inhibitor-based therapy is for patients with angiomyolipomas presenting with a significant risk of hemorrhage. Now, we've defined it in the paper, but it involves age, gender, lesion size, and there's other aspects that go into it. But if they're at an increased risk, then treatment is obligated. And to consider mTOR inhibition in all patients with a growing angiomyolipoma that's greater than 3 centimeters. Also, in patients who've gone on to kidney transplant, consider immunosuppressive therapies that use mTOR inhibition to help suppress the other aspects of TSC in those transplant patients. What about kidney imaging? Probably makes perfect sense to perform kidney imaging at the time of diagnosis, because this is one of those facets of TS that changes over time. The first imaging may be negative, the next 2 or 3 may be negative, but then you'll see angiomyolipomas and cysts and so forth. MRI is really the preferred modality for detecting and monitoring kidney lesions in tuberous sclerosis. In children, ultrasound performed by an expert radiologist who routinely images renal tumors in children is an acceptable alternative if an MRI cannot be done. In adults, ultrasound just can't get through the mass. And so a contrast-enhanced CT is an acceptable alternative to MRI for this purpose, but there's the risk of radiation and repetitive contrast administration. In children, we have an advantage because they will be undergoing MRI of the brain to monitor for sagas, for subependymal giant cholesteatomas. So the suggestion is that when they have their brain imaging, you can do the kidney imaging at the same time. Most centers, this isn't actually technically a hard problem, and most centers don't have a problem getting this done. And then the recommended imaging frequency is at intervals of every 1 to 3 years. And then the growth of kidney masses should be assessed using the same imaging modality. So if you're worried about growth, for example, don't mix between ultrasound and MRI. Use an MRI to actually see the growth. In the paper, we have a algorithm that helps in sort of how to follow adults or children with TSC and an angiomyolipoma. And the branch tree is, are they bleeding? Is their tumor bleeding? If yes, then really it's radiologic intervention if it's available and possible, and do the embolization. Now, some are small bleeds, and you can medically manage these. They're not dropping the hematocrit, they're hemodynamically stable. If you can't have interventional radiology do anything and it's urgent, then surgery is an option. If there's no hemorrhage, is there a risk for bleeding? If there is, if they have features that would make you think they will be at risk down the pike, then starting an mTOR inhibitor is appropriate. If not, then actively surveil the patient, and we have information to help you do that. Once you start the mTOR inhibitor, do they respond? And if they do, great, continue that and keep watch to see what's happening. If they don't, then it's actually very valuable to explore the dosage in adherence, and then consider the lesion type. And if it's still growing, then consider alternative treatment strategies. What about the dose of an mTOR inhibitor? How much do you use? In adults, since everolimus is the one that's approved, in adults, we actually suggest starting at 5 milligrams as a reasonable starting dose. In children, for angiomyolipomas, it's reasonable to start at 2.5 milligrams per meter squared. And then obviously dosing will require individualization and adapt to the patient's situation. If they have side effects, you can do dose adjustment for mild side effects as opposed to immediately stopping the medication. And then we recommend and find it useful to obtain everolimus troughs if there's safety concerns. You're not sure they're taking it, or there's no effect. And then we really caution not to exceed a target trough of 15 nanograms per ml. Now, the first thing we have to tell you is that the randomized controlled trials that are out there, and the recommendations are for 10 milligrams a day for adults or 4.5 milligrams per day for children, but you can start at a lower dose. If they respond, it lowers the chances of side effects. And then sirolimus is certainly a reasonable alternative to everolimus. We talked about starting an mTOR inhibitor and then seeing if the patient responds, how do you define a response? And there's obvious ones. For imaging, the volume of the tumor shrinks, or the growth stops, or slows, based on everyone agrees, yeah, it's much better. In the absence of new aneurysm formation. In the EXIS-2 trial, the population that were entered into the trial, it had a bleed a year before. So about 6 of the 118 patients had a bleed before we started the trial. 5 years after people went on drug and stayed on drug, there were no bleeds. So we suspect that suppresses aneurysm formation, so it's reasonable to do that. You can also consider a response of symptoms, individual assessment of the patient. If all the symptoms and so forth are controlled, that would be good. Pain, for example. And for fat-poor lesions, reduction of volume or growth arrest for the tumor, it's a response. Well, what about how long do you treat and stopping the medication? But if the patient responds, and the tumor is shrinking, and you can continue it because the patient's tolerating it, you should. We recommend continuing for a minimum of 12 months before assessing for a response, because there can be delayed responses. And if no response to an mTOR inhibitor by a year, then like we talked about, look at adherence. You can talk to the family, you can get levels and that sort of thing, and then confirm that the lesion really is a typical angiomyolipoma. Now, to discontinue the drug, one of the important things is if they have severe infection or have severe adverse effects of grade 3 and higher, then you should pause the medication and you can start back or start back at a lower dose. And the side effect profile using the mTOR inhibitor in the TS population doesn't seem to differ at all from the general population. What about surveillance, radiological and surgical approaches? Radiological and surgical interventions should be offered in angiomyolipoma hemorrhage with hemodynamic compromise. Obviously, this is something that needs to be done quickly. In cases with a significant bleeding risk, that you can't use an mTOR inhibitor, then I would just, discuss this with the family and discuss this with each other. A radiologic approach would be a reasonable step. For example, an embolization to treat angiomyolipomas that don't respond to mTOR inhibitors would be appropriate. And then really radiologic intervention is the first approach in cases of bleeding that require intervention. We recommend the use of the steroid prophylaxis to suppress the post-embolization syndrome. It works very well, and you don't have to give high doses of NSAIDs, non-steroidal anti-inflammatory drugs, to patients already with CKD, volume changes, and that sort of thing. It's just a much easier and better approach. And we recommend not routinely performing nephrectomy in patients with TSC undergoing kidney transplant. Now, there's caveats. If you need to do it to get the graft in place, or you're worried about true malignancy in a lesion or a very high risk of bleeding, that's a different situation. But just routinely removing it, it's not logical. And in cases with suspected malignancy, without suspected malignancy, then using tumor enucleation is preferred over resecting the tumor with a margin, where you destroy as little functioning kidney tissue as possible. And in cases of hemodynamic instability and ongoing bleeding after an embolization, then a radical nephrectomy may be required if you can't control it. But obviously, this is a last resort. What about biopsy and the management of renal cell in patients with TSC? We don't recommend routine kidney biopsy of all fat-poor lesions because you'll have so many angiomyolipomas only. We suggest obtaining a biopsy of fat-poor lesions if they're growing more rapidly than they ought to, 5 millimeters a year, or if they don't respond to an mTOR inhibitor. And surgical intervention has to be offered for treating histology-proven renal cell carcinoma in patients with TSC. And we recommend using an mTOR inhibitor as first-line treatment for FAT4 lesions requiring non-urgent treatment. So really, the treatment strategies for histology-proven renal cell carcinoma in TSC patients is not different from the general population, but really trying to use nephron-sparing surgical approaches to reduce the damage to the kidney, because patients are going to have multiple lesions and they have already an increased risk of chronic kidney disease. Well, let's go back to Ben. If you recall, here was this large FAT4 lesion in his right upper kidney, his small lesion here in his left, and all the cysts. The family opted for mTOR inhibitor therapy, and I thought was a good idea. And after 5 years of therapy, this was his most recent scan. Now, he still has cystic disease. As you can see, it's substantially improved. You can see a remnant of this large right upper pole lesion. And I can't find, it doesn't mean the left one's not there. It's just below the resolution or in between the slices. But over time, there's been a significant improvement in this patient's angioimmunopathic tumor burden. Well, I want to introduce you to Ina. She's my niece. I'm really just proud of my niece, but she exhibits an important family trait, and I've probably shown it to you this morning, or my morning, your afternoon, putting your foot in your mouth. I may have said something that's confusing or doesn't make sense, or you have questions, and I'd be very happy to answer questions at this point in time.
Roman?
Thank you very much, John, for this wonderful presentation guiding us through the current state of the art of how to treat the renal manifestations in TSC and also how to monitor, which is another very important aspect. Before we move to the actual question session, and we already have some questions here, which we'll now have the chance to ask to John Bissler. Jalila, you want to point out the upcoming next webinars?
Go ahead.
Now, we just really quickly wanted to introduce this because this series has been very important. Want to point out some very good upcoming presentations over the next 2 months, actually, only starting in March with a presentation by Marina Vivarelli on C3 glomerulopathy, and giving an update how we classify and also how we treat this disease, and we'll continue in April with Dieter Hafner's talk on rickets in children and adults. There will be more coming up in May, and you can see this here. You can register on the website of ERKNet, so we invite you to be here. Now, having said this, and having seen this wonderful presentation, I would suggest we start with a question round. We have a couple of questions already which we would like to ask, and you feel free to continue to add more questions to the question section in GoToWebinar. The first question here is John, do you see any role for dividing the doses of everolimus over the day, or would you give it once daily?
Yeah, that's a great question, because some children will take anticonvulsants multiple times a day. I actually prefer to give it once a day, and there's 2 reasons. One, there's the probability reason, and what I mean by that is if the family is 90% of getting the medicine in at the right time, if you give it once a day, it's 90%. If you give it twice a day, it's 81%. So the likelihood of getting it in is lower. And then the second one is that when we talk about blood levels and that sort of thing, the blood levels that we have established are for kidney transplant. And it's really a function of the dose getting in, the protein, the mTOR inhibitor binding to FKBP12, that interacting with mTORC1 and the reassembly of mTORC1. So it's actually this whole complex thing. We don't have the kinetics of any of that. And the mTOR inhibitor is so lipid soluble. I think once it's in, it's in. I prefer once a day by far. It seems to also has the potential to limit some of the mouth sores in some patients early on from our transplant population experience.
I think, I mean, considering both the pharmacokinetics of the drug and our clinical experience, right, there's not much of a reason to split the dose necessarily when you think about the effect. Another question here is, what do you do when patients undergo elective surgery? Do you pause medication when considering potential impact on wound healing?
Yeah, so that's important because the use of the drug was in kidney transplant was associated with issues with the Hissens and that sort of thing. But that's significant immunosuppression. It's not used in isolation. But still, having said that, for major operations, we recommend holding the drug a week before the operation and then 2 to 3 weeks after, depending on what the procedure is, just to limit any possible effects on wound healing.
Another question. Oh, sorry. Another question from our colleague Bert Bovens. He's asking for drug holidays in the well-responding patient. Would you stop it temporarily, and when would you restart it?
I would give an example of when I would do that. In some female patients, there can be significant issues, effects on menstruation. And so, for example, what I have done is in some patients who have this issue, we'll take them off drug for a week, and honestly, they'll cycle, and then we put them on drug again. We'll do that about 4 times a year. That's just my style of doing that. As far as a drug holiday, I don't understand I don't see a need or logic for that in most patients, so I don't do that. Long drug holidays have the risk of having renewed issues with mouth sores when you restart it. So a week, for example, is not a big deal, even 2 weeks or the 3 weeks post-op. But if you wait a few months, you'll have renewed issues with aphthous ulcers and that sort of thing. So I don't do that.
This also comes with the question, actually. You know, you already talked a little bit about criteria of drug holidays and so on. How do you deal with the situation of pregnancy? Because that has implications, right, for the angiomyolipoma itself and therapy.
So that's a wonderful question. I'm really grateful that someone asked that. What we end up doing is for patients who are on drug and want to become pregnant, then we obviously take them off a few months before they choose to become pregnant, and then monitor them closely through pregnancy. We're actually working as a group trying to put together cases and approaching this in a logical fashion to see what the actual risk is. So stay tuned. There'll be publications probably in the next year or so to come out on that. But the question is, what is the true risk of angiomyolipoma growth? I know what I have seen in the literature, and this is another one of those funny things. What I see in my patient population is I don't see massive sudden growth using MRI, for example. I don't see that. I've had lots of patients who've been pregnant by choice, and I've not seen a huge exacerbation of the disease process. I have patients that will be on drug, for example, for several years, but it's a planned thing. Okay, I'm going to become pregnant. So they'll use drug for several years to minimize, to optimize the shrinkage, and then go for it, go for the pregnancy. You may see some growth, but you never see it go back greater than the size was when it started. There's a funny aspect to that. mTOR inhibition in some cell lines and some tumors cause immediately almost a 50% shrinkage in cell volume. That goes back to cell volume issues from Ito and Rubin in 1999, the cell paper in the Drosophilus, right? The eye size was twice as big as normal in the Drosophila. If all the cells shrink by 50%, you might get some growth after that, but you'll never see it exceed the baseline size.
We have another question from Mark Lillian, who is discussing the recommendation of nephrectomy in contiguous gene syndrome prior transplantation. Would you do it in all the patients? Would you do it unilateral, bilateral, or not if not needed?
So cystic disease, polycystic disease, sort of globally, as time goes on, the tumor, the kidney volume does shrink. And so in the polycystic disease, I don't routinely do nephrectomy. That would be an example of, well, you have this huge parental kidney going into a small child and you have to do it just for size management. I would consider it, but I wouldn't routinely. The answer to the question is no, I would never routinely remove the kidneys. But I certainly would consider an mTOR inhibitor as part of the immunosuppressive regime, because you're treating also more than just the immunosuppression, you're treating other aspects of TS.
I think that's a very important point. And I mean, what we've learned, you know, if you extrapolate from the ADPKD population, right, considering the lack of growth after transplantation, even shrinkage and so on, there's many reasons to say a routine reflex to do something is probably the wrong way to go. There's also the question whether you would recommend imaging of the liver.
Right, so that's one of the benefits of using an MRI is you get that. You can do about 15% of TS patients, at least the ones I see, have liver lesions. They have angioadenopathies or more vascular appearing lesions. Generally, that doesn't do much. Those lesions don't do much, and they do respond to mTOR inhibitors. That would be my answer. You can do ultrasounds, but you're going to be stuck with the same issues. You may not see lesions that are more fat-forward.
Agnieszka highlighted a very important thing is what about more information about sirolimus? Does it have a place? Because a lot of countries maybe don't have access to Votubia and don't have reimbursement criteria. What is our opinion on sirolimus?
So sirolimus was the first drug I used. That was the New England Journal of Medicine paper in 2008. I use it. The honest truth is, I probably use more sirolimus than everolimus. I have a very large patient population, not limited to the U.S. The doses I often use are somewhat lower, but it works just as well.
Osayusi is asking about a patient with lymphedema in the context of everolimus. Did you saw this side effect, and is it really related to everolimus itself?
I have seen it, and it's dose responsive. So I've used lower doses. So when we did the registration trial, we used the maximum tolerated dose. In the sirolimus trial, we kept increasing the dose because we didn't know what was going to happen, so we kept upping the dose to see what would happen. It turns out that most of the patients I deal with can respond to very low levels. I have patients on 2.5 of adult patients on 2.5 of everolimus or 1 milligram of sirolimus, and they have 0 blood levels, but they respond just as well as other patients. You have to individualize it, but that you can use much lower levels. When you use low levels like that, the drug-associated lymphedema improves greatly.
We also have the question here whether you would recommend to then perform surgery if an angiomyolipoma is really large, like 9 centimeters, embolization failed technically, for example, and everolimus is not tolerated. So if the only option is surgery, what would be your indication to go for it?
So that's a great question. The first one is, for me, the goal of an embolization is to eradicate aneurysms. The angiomyolipomas bleed because of aneurysm development. Aneurysm breaks and bleeds. And you can see them on a non-contrast MRI. They're a flow-void. Actually, in my mind, I liken them to like Christmas tree bulbs hanging off the Christmas tree. It's pretty obvious. So that's why I would do an embolization. So a failed embolization means, well, the lesion didn't shrink enough. But if there's no aneurysms, the risk of bleeding is remarkably low. Then the tolerance of an mTOR inhibitor is a function of, well, what dose did you use? How low did you go? You can lower the dose to see if it's tolerated. And then as far as the surgical approach, the size isn't as big a deal if the rest, depending where it is, if the kidney is functioning. Almost every patient I've ever done a MAG3 study on the TS, regardless of the huge tumor burden, the kidneys are about 50-50 as far as function. So I would limit surgery, if it's a 9 centimeter exophytic lesion and the patient wants it gone, even though there's no aneurysms, that would be a discussion. But if it's a big lesion in the kidney, if there's no aneurysms, I probably wouldn't do surgery. I would actually try a very low dose mTOR inhibitor to see what you got.
This may also be linked to the fact, that's a question of my own actually, discussing no response to mTOR inhibitors as a reason to stop the therapy. Is this something you would say that is common, that there's really no responsive treatment is given in a typical AML?
So I think that gets back to something I mentioned earlier. I'm going to use the 9 centimeter one just to sort of follow and play this game. You have a 9 centimeter tumor. And they're on an mTOR inhibitor, and it's stayed that size for a couple of years. The other thing you're doing beyond giving the mTOR inhibitor is you're suppressing aneurysm formation, right? In the EXIST-2 trial, the long-term follow-up shows you they don't hemorrhage if they stay on drug. If they come off drug, then there was a hemorrhage in a patient who went on drug, had a nice response, went off drug, a year later did bleed. So for me, that's why the definition of a response is really important. If you stop growth, you can give drug and suppress aneurysm formation, reduce the risk of bleeding. That's a success.
For the last 2 minutes, I have 2 provocative questions for you, inspired from the PKD world. As the TSC and PKD are really in parallel, would you give tolvaptan to a contiguous gene syndrome? And my last question, Roman will love it, is ketogenic diet is now used for epilepsy in TSC. What is its effect on the kidneys?
So first for tolvaptan, this is outside of the work outside of this this paper, this presentation, but the cysts in the contiguous gene syndrome in the TS patient are actually lined with type A intercalated cells. And contrast that to in ADPKD, they're lined with principal cells. Why am I making that distinction? Well, principal cells have hoisted on their surface the receptor, the V2 receptor, I'm sorry, the ADH receptor. Yeah, yeah. The issue is intercalated cells don't have that. The cysts in TS do not have the receptor that would be blocked by tolvaptan. So I don't know that it would be useful. I have followed patients, international patients who have been on drug, been on tolvaptan, and it's done nothing. I haven't gotten a recent follow-up, but after about a year of therapy, patient had still continuing growth of their cysts. That's nothing, it's one patient. but I wouldn't do it because I don't think it would have an effect. Now, as far as the ketogenic diet, we use that extensively in seizure control for TS, and it doesn't seem to alter the cystic burden to my eye. Now, I haven't done a systematic approach, and you're right, I should. But my overall impression, I haven't thought, ooh, I need to look at that because it's different. They seem to be similar. But I do salute the provocative questions. Thank you.
Thank you very much, John, for this very exciting and interesting webinar. Thank you, Roman, for being
moderator.
Exactly. But also in the paper. And I thank you, Stephanie, for organizing this. And we wish you a very nice day.
Thank you
Bye.
all.
Thank you very much. Have a nice afternoon.
Thank you all. And thanks for all of the attendees today. We had a very interesting discussion here, I must say. Wonderful. It was a wonderful setting here.
Bye.
Thank you.
Bye.